everybody got their chapter 44 PowerPoints out? Ready? I don't have much on this. This is what you were supposed to be doing next week for week 7, but since we're not going to be here, we're all going to be eating, hopefully eating good food. We'll just kind of start with part of it today. It's not that hard. GERD, peptic ulcer disease, and C. diff. Unfortunately, everybody's probably had you've had a fun experience with C. diff. I hope you don't have another one. Can I get everybody's quiz? Funny that we're eating lunch and talking about the stomach. Y'all are going to be like, oh my gosh. And all of a sudden have to go to the bathroom shortly.
How you know you're going to be a nurse when you have strong stomach?
Oh, yeah. We used to eat. It didn't phase us one bit. You gotta eat, you gotta eat.
I'll also get to those autopsies.
I get Jennifer that number and I told her every time to call.
And you could tell her to remind her about this.
Oh, yeah. Alright, do y'all remember back from level 1 when you did? If you don't, you're like, no. Here's just a good review of and it's got all your hands out, okay? This is your belly, where all your organs are. And it's got all your pictures and flashcards. Just so you know where all the organs are, your precious memories. You don't like that? Alright, so this one's pretty simple, straightforward. Y'all are going to like this because it's pretty common sense. But there's a lot of good info on here that'll help you on your tests. Alright, digestive tract. We're all probably going on overdrive right now. So it's a muscular tube, right? You know, from the very beginning to the very end, it's just one big long tube, the GI tract. Muscular, that's how things move. We have muscles in our esophagus that squeeze that food down, right, when we talk. We have muscles in our stomach that turn the food. We have muscles in our small intestine because it's just like a train track. It's got to keep going down the track or we get constipated, right? Then once it gets to the colon, or the large intestine, that's where everything is pretty much that can be used has gotten out and all that's left is waste. So that's why we have the large intestine, the colon is pretty much just the waste, the feces that's there, and then it excretes. But the whole tube is a muscle, okay? Again, since we're talking about neuro, those kind of patients where those nerves aren't going to the colon, telling that muscle move, that's why they get constipated, right? Because now there's nothing to tell those muscles in the GI tract to move. It's your consists of your mouth, your pharynx, your esophagus, small intestine, or stomach, small intestine, large intestine, and anus. All those accessory organs there are aid in digestion. Also, tell me what's an accessory organ that aids in digestion? Pancreas. What does the pancreas do? Why we need it? Excretes insulin. Very good. We know that when we eat, everything digests and eventually turns into a glucose. So our body produces insulin naturally in the pancreas that helps lower that blood sugar. What's another accessory organ that is used in digestion? Gallbladder. Yep. Yeah, your gallbladder, it stores bile, and when we need it to be excreted to help digest fats, the gallbladder squirts it out. Okay. This is real just basic A&P overview, okay, y'all? We're going to fly through this, but you've got your PowerPoint, so don't feel like you've got to write everything down, because this is probably just a review. Marks the mouth is where the entrance of the digestive system. We know that contains our tongue, and we have to use our tongue to help swallow, right? Chew everything up, it kind of helps the food move around. Digestion truly begins in the mouth. We're going to be honest about it. What is in the mouth that starts the breaking down? Saliva. It's got enzymes in it that start immediately breaking things down. And then also your teeth are another part of your digestive tract because that's a mechanical thing that's tough and chopped up to begin with. It's really difficult to swallow something solid if it's not broken down a little bit, right? We can choke. Unless you're really good at swallowing stuff. I don't know. Wow. I mean, it's not. What? I don't know. Just say it. Y'all went there. Change the slide. So your esophagus is the tube. Like I said, it's in your. It's behind your trachea, right? If you feel your windpipe, then right behind that is where the food goes down. When you swallow, that's your food tube. 25 centimeters long, and it's just basically the tube that gets food from your mouth down to your stomach. It's just a functional thing. Remember I told y'all the body doesn't do anything that's not a function. Everything has a function. Okay. Then the stomach is just where your digestive proteins are that start breaking things down to begin with. It's basically just a pouch that moves. It's a stomach it's a muscle with lines in it. Does anybody remember what the wrinkles are called? Rugae, and it just squishes and squirts, and it turns food into chyme, or I don't know if it's like chyme. How do y'all say it? Chyme. And it passes food. There's a little sphincter. You know, we got lots of sphincters and lots of places. And at the top of your stomach is the pyloric sphincter. I think it's on that. Maybe it's on the ones that's listed on there. Maybe not. But it's at the top, and so of the stomach. And then into the duodenum you have another sphincter, and that's where it's just like a door that helps let stuff in and out, letting it go through to the next phase and down the track. Okay. The small intestine, which is the one that always to me look like worms, it's just real wormy and it's longer, and it that's where actually most of the digestion takes place. The small intestine is where you're going to absorb everything. That's where your body's going to use what you've eaten. It's going to get absorbed, broken down into a cellular level, and then goes out into the blood circulatory system. It's absorbed that way. So really, people think that all digestion happens in your stomach or absorption happens in your large intestine, but truthfully, you're really getting everything through your small intestine. All right, and it has a little villi, remember the little fingers that help move things along. So just know absorption takes place in the small intestine. Okay, and then your large intestine, like I said, is the last major part of the digestive tract, and that's where everything that could be used has been used, and this is just the waste. It's literally the waste. It's what's left over. The body can't use it. So absorption of food and nutrients doesn't take place in the large intestine. It just passes through because that's waste. It knows I don't need that anymore. But if you were dehydrated, it's still protecting itself. The body will still protect itself, and it will reabsorb water, the large intestine or the colon. So if you're bad enough dehydrated, it says, hey, I know you're waste, but you got some liquid and I'm dry, so it'll soak back up what little bit of water is left out of that stool. And so what does that lead to when you have a dry stool? Yeah, an impaction and constipation, because you've sucked out all the water out of that large intestine. Okay, and then the rectum, it's the last little 8 inches of the GI tract. And that's where when we're doing a rectal suppository or rectal exam, or you're checking there, that's called the vaults too, because the feces can get lodged in there. So we go through the anus, which is the last sphincter. Do we need to remember how long there? No. I don't think they would ask you that, but just to give you an idea, it's 8 inches. That way you don't want to put anything bigger than 8 inches in the rectum.
Just so happy.
Y'all are awful. Y'all are dirty girls. basics, okay? Now here's your accessory organs. I'm going to talk about the liver. We forgot about that one over there. What is the liver? No, I didn't hear you. I'm sorry. I didn't mean to kick down. I lost my liver, gallbladder, and pancreas. Okay, so those are your things that are your accessories. They're a big part of digestion. What is broken down by the liver? The fat. But what else? Why do we need our liver? What else can we take daily that is broken down by the liver? Who said alcohol? Are you a daily drunk? Meds, right? Some meds are broken down by the liver. But yes, alcohol is filtered through there. Y'all are fun. This side of the room's fun. Y'all are party girls. Okay, so the liver produces bile. It's actually where it's produced, and then which is necessary to break down fats. And then that's when it's stored in the gallbladder. The gallbladder is just like a little pouch, right? A cyst, like a little place that we keep stuff. All right, and it helps. The liver also helps manage blood coagulation. It realizes when your blood's too thin, so it might put out some platelets or things like that help clot your blood. And it helps break down or metabolize proteins, fats, and carbs. Manufactures cholesterol and albumin. So people who are in liver failure, their liver's not working anymore, you think their cholesterol levels will be high or low? High, because it's not breaking it down. Right? Because, again, the liver metabolizes fats. And so if you're taking in a bunch of fat and there's nothing there to break it down, cholesterol level builds up. And so you're going to have elevated cholesterol levels. Well, it does make that too, but it helps. What is fat? What is metabolizing? Breaks down. If your liver's not working, it's going to be elevated because you're not breaking down the fat. That is cholesterol.
Read your PowerPoint.
I'm sorry. But yeah, I see what you're saying. But just know that if they're not, because it's not breaking down. So our dietary pills are not addictive. So he makes a good point. There is 2 different kinds of cholesterol. The liver's making the good kind, the one that we need. But the ones that we take in, like from foods that we eat, that's the fat that your liver is metabolizing. Get rid of. And if your liver is working, your cholesterol's high. Okay. Also detoxifies poisons like alcohol. If you're drinking, that's what filters it out, right? It keeps us from going into alcohol poisoning. So if your liver is not working as well, there's a lot of time to get a little drunk faster, or you're really sick from alcohol poisoning. And the other thing that liver does, it converts ammonia to urea. Ammonia is a byproduct, and so it takes that and turns into urea, which what urea turn into. That's how it extracts a lot. So liver's really doing a lot of work. It's a full-time employee in the body. It does a lot.
Like minimum wage.
Yeah, it's not employee of the month. We treat him so bad. But he does a lot of work behind the scenes that we don't even know about. And then there's a little gallbladder who everybody knows about. And I think I gave y'all, did I give y'all one for gallbladder? A little handout on here? Maybe not. I think I have one. I'll find it. But the gallbladder, which side is it on? Which side of the body? Right upper quadrant. The liver's on the left, and the gallbladder's on the right upper quadrant. And so, because the liver's over here, and it says, okay, I've made my bile, and it takes it down to a little tube, and it stores it there in the gallbladder. And so, like I said, when we need something to help with digestion of that fat, it squirts out the bile. Now, has anybody ever had the gallbladder go bad on them, like a gallbladder attack? Anybody had an attack already? Left side. Liver's on the left. Look at your hand out, y'all.
Liver's on the left, on the right.
Sorry, did I say, okay, yeah. Sorry. You need to eat again. What is it? Liver's on the right, and the gallbladder So, but just know that the gallbladder stores the bile. That's really its only function, is to store bile. So, that's why we can take it out, right? Because sometimes they get full of gallstones, which what are those called? You know it.
Urolitis.
Chole.
Oh, God.
She's like,
yeah, you got
it. Sort of had it. Chole is gallbladder, right? It's stones. It sounded. And so, if we've eaten too much and we have too much fat in our system, those stones build up, and then you get the gallstones, and it hurts, right? And it has to be taken out. What kind of foods make your gallbladder hurt? Like greasy. Yeah. So, I have a bad gallbladder, and I refuse to get it taken out because I have bad experiences with past surgery. So. And it's so simple. They go in, through your belly button and just take it right out. But not me. My life is never simple, so I would be the 1 in a million person that would have some kind of perforation of every major organ. So I'm not doing it. Yeah. Not going to do it. I'm just going to suffer. And so I try not to eat fried, greasy foods because, oh my gosh, it will cramp and hurt. But they are good because when I break down and eat some, and then I'm like, oh my gosh, oh yeah. And there's nothing because it's cramping. It says, okay, you ate a bunch of greasy french fries, squirt out some bile. But those stones are in there blocking it, and so it can't get out, so it cramps, and it hurts, and it just doubles you over. And then finally, when everything passes through, there's nothing to break down the fat, so it shoots through you like grease lightning, and that's when you get the gallbladder splatters. There's nothing to form it, it's just straight. So people who've had their gallbladder out, or people who have stones and the gallbladder's not functioning properly, they might have explosive diarrhea because after eating a fatty meal.
So I'm confused. What is the cholelithiasis? Gallbladder stones. So there's a difference between gallbladder stones and kidney stones?
Yes. Okay, because it's 2 different organs. 3 different organs. You have kidneys and your gallbladder.
So that's why I don't like.
So gallstones and then chole.
Chole means gall, uro means
and then the cholecystitis.
Inflammation of the gallbladder.
Yes. Cholecystitis is gallbladder inflammation, right? So just kind of you'll recognize breaking those words down. Alright, so gallbladder, just know you can't have lots of greasy foods. I think I have a handout I'll give y'all. Alright, pancreas. Now this side, I know this. Where's this one located? This one's on the other right. This one is up on, and then what does it produce or excrete? It produces insulin and excretes it, and we know that's to help with keeping our blood sugar level. Okay. And then carbs turn into glucose. So just because a lot of people, and this is a huge teaching thing on diabetics, because it's so complex to be a diabetic, and there's so many different ways, and there's so much bad information out there, and people have so many preconceived facts about it. But any food you eat breaks down into carb, okay? Anything. And so carbs turn into sugar. And so people think, oh, I'm a diabetic, I can't have sweets, but they'll eat a loaf of bread. What does bread turn into? Sugar. So then you tell them, no, honey, you can have it. No, I can't have any sugar. My doctor said, no sugar, I'm diabetic. I got to take my insulin before I have it. Okay, well then go eat that. I guarantee one piece of cake is only going to raise you up 100 points, or that whole loaf of bread or pizza you just ate is going to raise your sugar to 1,000. They don't get it. So you have to explain to them that carbs turn into sugar. You have to just carefully pick what you're going to eat all day on a certain amount. So they've come up with this new thing they used to say, you can only have 1,800 calories a day. They don't do that anymore. They just say dose for what you're eating. So it's like for every 15 grams of carbs, you would give yourself 1 unit of insulin. So the doctor will assign you a ratio. Sort of like a sliding scale, but with just carbs. Because now we know everything turns into sugar. So just know that that's what the pancreas is doing. It's helping produce insulin and get that sugar under control. What is our pancreas? Our pancreas isn't working to begin with when we're a baby. What type of diabetes is that? Type 1 juvenile. Starts when you're little. You're not producing any at all. And then as we age, we've eaten all this good food all our life, we've gained a few pounds, and now our body mass is too big for that little tiny pancreas to produce enough insulin. So we're producing insulin, just not enough. That's type 2 that we develop later in life. Okay. All right. So if you're getting an upper GI, that's one of those diagnostic tests. We do the scopes. You can get. You have to be NPO. Why do you think you have to be NPO? What are we testing? We're looking at the GI tract. Do I need a bunch of French fries and hamburgers down there? No. Unless you want a fun day. So you keep them NPO prior to the exam because we want that to be emptied out. Alright? Sometimes they give them some stuff to swallow to help like go lightly and stuff that helps get all that out of the digestive tract. But usually you make sure your patient's NPO. If you're the nurse that's taking care of this patient, they're going to get an upper GI. You need to make sure. When was the last meal you ate? Sometimes they'll lie and say, last night. And you see the crumbs all over their face.
12 hours ago.
Okay. Whatever. But then no smoking. Why can't you smoke before an upper GI? What does nicotine do to your stomach acid? It stimulates increased output of stomach acid. So that's why they say no smoking before that, because we're trying to get a good, because they'll check the pH of your stomach too when they're doing this, and they want a good accurate example. Okay? Oh yeah, that's why when after you eat, don't you crave a cigarette so bad? Because your stomach's so full, and you want that because your body recognizes, even if you don't, that it's triggering digestion. It's worse because if you smoke on an empty stomach, you just have it really bad for burning all that acid.
Are they awake when it's done?
They give them something usually it's like Versed or something that they're, conscious sedation, but sometimes they can. It just depends on what they're doing. If they're like real overweight and they're worried about apnea, they'll completely knock them out and intubate them. And then that tube's in the way though for the scope, so it just depends. You know what a barium swallow is? Do y'all know what that is? It's like so it's the radiopaque dye that you swallow, and then they can do an X-ray too to make sure that you're like a highlighter. It just glows the whole part, so then they can see where your injury is if you do a barium swallow. And that's another reason why you don't want to be full of food, because then the food absorbs the barium swallow and then the test is invalid. So another reason to be NPO.
Have you seen any like
colonoscopy with the day they swallow the pill that has a camera on it?
Oh, that's cool.
Yes,
That'd be a lot easier.
Well, I had to search for one after a resident passed it, but yeah. Yes, I've had 2 days.
That was not a fun day.
Never found it.
Oh God.
Yeah, but it sends it back to the physician's computer. Like it's really cool.
What do we have to worry about on barium? What do we check for as a nurse? The incretin for sure, because we want to make sure that this is in allergies for sure. Because this is going to be in their system, we're swallowing it, so it's just like anything else. It's got to go through the digestive system, circulate through the body, through the kidneys, to be excreted. If their kidneys aren't functioning, their beta-creatinine is off, then do we want to give them a barium? No. Because then that nuclear medicine is going to stay floating around their body for a lot longer than it needs to be. Also, we check for, like she said, allergies, because what do we know we need to be checking for? What kind of allergies? Same one for everything. Radioactive. Yeah. Iodine shellfish. Seafood. So gastric tube, this is something, they go in and just check the GI stomach acid. You can look at that in your book. It's not real common. It's kind of the same thing. NPO, no smoking. And they'll insert it in your tube, aspirate out the stomach acid or the stomach contents and check the pH. It's not a big deal. EGD, this is the one where we put the scope down for sure, and then same kind of look at all the interventions, they're the same. NPO accident. Because we're going down the same system, right? So it's not going to change. We've got the same function. We're trying to look at a stomach, so we want to make sure they're NPO. Alright? Make sure that they're getting all that barium out rectally later. And it looks, y'all know what it looks like when it comes out? Somebody said it earlier, I thought. chalky, what looks like mailbox.
I said chalk.
So just kind of know about the EGDs. That certainly these are people who you want to make sure they're able to swallow. Will we give somebody who just had a stroke this? Probably not, because do we want them to aspirate into their lungs, this dye? So always make sure that you're doing that. And then for EGDs, we want to make sure that they're controlled in an environment, because they probably will be sedated. So what do we do afterwards? What are we going to be watching for? Respiratory issues. Anybody that's had anesthesia or sedated, we always watch, make sure they're breathing good, okay? Keeping that IV, because in case they do stop breathing or have an allergic reaction, we have IV access that we can shoot meds through quick to get them back to life. Always monitor vital signs and respiratory status. Here's the barium. It's the same thing as the other thing. They're swallowing this yucky stuff, and they either shoot an X-ray or do another type of scan, like CT or MRI, and it shows where along the GI tract there's an injury. And so that's what that one's for. Same thing, keep them in PO, and then make sure that all the barium is expelled rectally. Alright. Stool and cold blood. Do y'all know what hemocold cards are? Anybody ever had to have those done? You have to do them for your patients. They smell so bad. There's nothing like 3-day-old food. That is a bad smell. They will bring those cards to you, and they're like, "Here's my samples." You open that bag, and it's like, "Whoa, awful." But these are the little cards that you have to get to check for blood in the stool. What does the stool look like if there's blood in it? You can visually see it. Very dark, tarry. I mean, it's like goo. It looks dark and tarry. Like if you were to take a spoon and do it like that, it would just be thick and like the consistency of hot tar. And so that's the blood giving it that dark color. And so somebody says, "I've had blood in my stool," the doctor will give them those 3 hemocold cards and 3 popsicle sticks. And they have to go and get that sample, smear it on the card, and they have to get 3 different samples from 3 different days. And then they bring the sample cards back in and give them to you. Now, and then you get to smell it. And it makes your whole office stink. You have to put the little stuff on there. It does. It's so bad. And they drop stuff on there and turn blood is positive for blood. Then that's when they'll order one of the other tests.
They can have blood in their stool without it being black.
Yes, yes. If it's microscopic, just a small amount, like let's say it says on here they just wipe and there's a little bit of blood, that could be a hemorrhoid, or they just, been too aggressive, I don't know, whatever they were doing. And so that's okay. But if it's in the stool and it's hard, you can't really tell, but it could be up higher. And so the blood has had time to reabsorb or digest back through the system. But usually if it's bright red and visible, it's a lower GI bleed. And boy, you can smell a GI bleed. It's a smell you'll never forget. It almost smells to me like dirty pennies. You ever smelled an old jar of change that people save? Go get a whiff of that. That's about what a GI smells like. Yeah, it's really a real distinct smell. Okay, colonoscopies. Y'all kind of know what that is. Same thing, NPO, but for 8 hours, because now we're going up the colon this time. Instead of swallowing it going down the esophagus, we're going up the colon. And so, yeah. They're going to have the bowel cleaning kit, like a Go Lightly or a bowel prep that you have to start the night before. And then that way the bowel is clean so that the scope can go in and visualize everything, okay? Not too much to worry about. You're definitely just going to watch their, they'll be conscious a lot of times for this one. They just give them like verse it so they can follow commands of telling bear down, and they have to be awake enough to bear down while they're doing the test. And so when they come out, they're kind of groggy. You just have to watch their respiratory status and vital signs. Stool cultures. This is if somebody's having really bad diarrhea or having fever and stuff. Maybe they have parasite. Where they're they check that. So they'll do stool cultures. Bacteria, ovids, and parasites. Has anybody ever seen pinworms?
Look in pictures.
Okay, it's bad. Pinworms are like little worms that they're at the rectum, and they itch really. It's usually in children. Sometimes it's in adults, but they itch really bad at night. And so you can go in with a flash flashlight or something, and you can put the light on their rectum, and you can see the worms. See them at night. They get real active at night, so that's why they have rectal itching at night. So that's what they'll do. That you have to collect a stool sample. Next time they poop, you have the little cup over the toilet, and you let them poo, and then that's when we take it and pour it into our sample cup and take it for a culture. And they watch to see what grows out. So, it's gross. It makes me itch now. Thinking about it. Like, yeah, I'm having butt itches. It's a bad day. Just thinking, I had to do that one time when I worked in peds, and I was like, oh my God, I didn't know that people existed. And it just makes you feel like you can't get enough showers to get clean. And I was like, I know I don't have butt worms. Why am I so itchy? It just drives you crazy. So just know, I will never forget, if you have pinworms, you shine a light, you can see them, and you need to get a culture for that, okay? Yeah, now everybody's butt's itching. Thanks a lot.
Don't start with Africa.
Oh, yeah. Don't worry, I'm not going anywhere outside the U.S. for a long time. I'm scared of everything right now. So, okay, so this is talking about mouth. We're just going to breeze through this. Y'all know what plaque is on the teeth. You want to be in caries, all that kind of stuff. You want to be encouraging good oral care, oral hygiene to your patients, brushing and flossing. You might see that term. What does that mean? Yeast. Yeast. You can have it in lots of places, and if it's in the mouth, that could be, it's called thrush, and it looks like milky curd-like lesions. They give nystatin or diflucan. You can do a nystatin wash, an oral rinse. It's like yellow stuff, and it kind of cleans the mouth and kills that yeast. Who are your patients that you would think would have that? Babies, for sure, because they're not doing enough oral care on them, and they're still just sucking milk, and they're not getting in. They don't even have teeth to brush, but you're supposed to do the little swab to clean their mouth, and you teach your moms to do that. But also, who else goes to dementia patients who aren't cleaning or aren't getting good oral care? And there's one other person or type of person that has. What kind of teenager were you? Okay. Diabetics are bad about getting yeast. Why do you think that is? What is that?
All the sugar.
There you go. Diabetics, blood sugar's high, and so what does high blood sugar? Yeast grows with sugar. So they will have a lot of thrush if their sugar's out of control. That's a telltale sign. You're like, I've been taking my insulin, and their mouth is just hovering. You're like, sure you have. So with the thrush, though, especially if it's a baby, meticulous hand hygiene, because we don't want to spread it, and just keep checking it and helping them if they're hurting with pain and give them over-the-counter stuff. But main thing is oral hygiene with that, because as we swallow that, if it's still there, it's going to get in the rest of your system. It's bad. Carcinoma of the oral cavity, in case you're working as a clinic nurse, or if you're doing oral care on your patient, and you may catch that, oral cancer. It can occur of lips, the oral cavity in your tongue, and pharynx. Higher incidence of patients who have in the mouth who have heavy drinking, tobacco use, and exposure to HPV, human papillomavirus. Why do y'all think heavy drinkers get oral cancer high risk? What are they doing or not doing? If you're drinking all the time, one, that's a lot of alcohol. That's heavy on your mucous membranes, real damaging. But what do? You go pass out somewhere. Do you go and brush your teeth before bed? So no oral hygiene. And then usually if you're a drinker, what goes along with drinking? Yeah. So those two are double whammies, right. I mean, it's a natural thing. It's a very natural, they go together like peanut butter and jelly. So that's why they're both high risk. Yes. So just kind of know that if you've taken their social history and they say, of course, drinkers never tell the truth. They're going to say they underestimate. I only drink a beer a day, a pack a day. Just a pack of smokes and a 6-pack of drinks. That's what they used to. So just kind of know that if they have that, you're going to really do a good oral cavity inspection for lesions, because they can definitely be growing some kind of cancer in their mouth. Who else has a high risk? Not real Because it was just so gross. They would just walk around and you see people in restaurants with Coke bottles sitting in it. Yeah, everywhere. And it's normal. And I'm thinking,
I hate whenever they ask you for a stick cup too. That is so nice.
and the worst part is they think that's better for them than smoking, but actually they have a higher risk of developing more cancer from it.
She would have to write stop. Please stop. Stop. Please stop. After you were imitating him.
Okay, that's our AMT review. And then we're going to go. Do y'all need a break or y'all want to? Yes. Let's go. She's weird. She's so weird. Maybe hyperemesis. You just were real nauseated with that?
Are you sure? Last time I texted you on that. Are you sure? Do you want me to pause to record aspiration?
It is a word for it.
So you're real sensitive then when you're pregnant?
Yeah, like I hate being pregnant. I do.
You know how to avoid that?
Yeah.
Well, a lot of it is from the milk. But it was like whenever they have stress, they have white in it, and then it's like you can see like little blisters, and it hurts. They can't swallow. They can't suck on the bone. And whenever they have their most of those don't keep that or has the like I think because they were all looking at that and stuff like that. They're like, I don't know. They're like, they said not to rub or anything. They were like, yeah, just like a and I was like holding her and I was all looking at her. That guy sucks. Okay, I'll go get it.
That's why what can you do right here? Hemoglobin down? You don't want it down. Hemoglobin's what carries your oxygen. Is it all high? Like all of the blood work high? Can there be high? That's good.
On the paper, like my lab results, they say like what is too high. They have that on there.
What? How high was it? Like if it's anything out of the normal, they'll put that on there.
Yeah, it was
Does
over the
she take iron pills?
No, that's how blood pressure.
Oh, okay. I wasn't letting her.
Maybe if anything, that's kind of down below a little. Does she take a blood pressure pill? And does she take a blood thinner, like an aspirin or anything?
Yeah.
Okay.
Oh, okay. She was all freaking out.
Hemoglobin just means your blood's going to be thicker. You know what I mean? You're going to carry more oxygen. But that's a good thing for women. But if she's hypertensive, and that's what they're worried about, prevent the clot. So maybe that's what it is for her.
Hey, so whenever I get out of school, you told me that you wanted me to go and drop it off, but I was going to see if you could wait to me, because I need to go when I get out at 2, I want to go home and change, and then I want to go see that bronchitis and that other one next door too, to see if I could get a job there. And then but I have to be done before 3 so I can pick up the kids from school. You don't. Okay, sounds good. I don't mind mind taking you whenever. Like when I pick the kids up, I don't mind taking you after that. Okay, alrighty, sounds good. And I'll see you in a little bit. Okay, thank you.
Yeah.
Oh my God, Gus just sent a text that says gobble your, or email gobble your burrito.
Understand what you're talking about and where that came from. What does it matter? Can I ask you to come drink today?
Gus is complaining about the copier and sweet being used too much.
Is he? Now he acts like he paid for the
Today just turned
What is
into
there,
an
dear?
awesome day.
What happened? Got money? Christmas money!
Christmas shopping.
Where is that from?
From this,
financial aid.
from my financial aid.
Like you were trying to do. Push the butter back out.
Oh my God. It's from where we have paid and then just the match. So you got Christmas. I got Christmas. Well, Merry Christmas.
Where do you go for that? Financial aid.
Where do you go? I need to go.
Why not for credit too, but they never gave me.
Go ask her now.
You have to go ask.
You have to find
I'm not
out.
going to give you money back.
I don't ever get lucky like that, ever.
I was like, you're not struggling forever.
It's like, you're struggling.
I missed you.
My brother told me to post something on a loan so I could get caught up on everything, and
Ask
we
her.
did it, and it was so confusing. I ended up putting my information on his. So this is how what an ass he is. I called him and told him, he's like, well, we can redo it or whatever. And he's like, yeah, but they can't run my credit again. I said, well, they're gonna have to, you know. Well, he was like, no, he blew up on me over text. It's like, they put your workplace on my credit score, and now my credit score went down. I said, your credit score doesn't go down because of a place of employment. He said, no, it dropped it a lot of points. I was like, you're tripping, but I said, if you didn't want to do it, you should have just said it from the beginning.
Today has been a pleasant day in class. Yesterday, I don't know what's going on.
Other boys? Oh, yeah.
Here, someone else can have this one because I can't. It smells too odd.
I don't want
Can't
to
handle it.
They give them to me for free. Everyone want these? Which is what Joe's got to match. Wait, give me one.
My oldest goal is 1026. So Mr. Jerome and matched it. So they paid the match.
Oh, no, I don't know.
26.
You have
That's the match plus
I
the
can put the aloe shop over there.
So, tea, you don't mix it with your tea?
Wait,
Your heart, it's warm. Cause all the blood is going right there. My mom up. I'll show about the kid.
Ooh, girl, I don't know.
So then you forget.
It's been an hour. I rented out my house in Livingston, and the people that I rented to, I guess they breed pit bulls, so they said they can stick them at my house. Which I told them in the backyard is fine, but no pets inside. But she said, no, we're not going to have them here. So then my neighbors, I should have known that they were going to do that, but the husband and the wife separately texted me and told me, can you talk to your renters, because the dogs are just constantly barking and barking. I'm like, I don't. You need to call cops. I can't do nothing down here.
Yeah, then you're, say I'm out of state, that's a rental. You can call the cops on them and the cops can go tell them, they're renters. Yeah, Carrie.
Well, what? Were you telling me? Yes.
I saw her walking by earlier. She's here, but they're back. Yeah, I saw her. She'll be
At the mall?
in Rockford. It's just a little jail. Just want the jail for their mental health.
Why didn't we get
I don't know, because I started doing such a gym because we were doing the blood unit in level 1. I took them over to the blood bank. We did that. And I was supposed to get blood. And they're supposed to be bringing the blood out of here, like extras for blood drive in December. And then we went to a field trip. We went to a field trip to see Z-Dog, the MD guy. That was really good. That was a really good speech he gave. So I like everybody.
We didn't get into that. For our dementia, we went over to, where did, Miss King used to work at before here? Carolina. And Allison just talked all her stuff. I was asleep and everything. You know, I'm a tired person. So I fell asleep. She woke me up. It was so boring. I was like, oh my God. We didn't get to do nothing.
This is the morning. Don't be like, come on. Okay, that's how I know we've taken too long, because my computer cuts off.
No.
Where is everybody? Okay, we're done for the day.
Oh, that's funny. Perfect.
look, this is just where this starts. So GERD stands for 1413. GERD is just, that's what it stands for, gastroesophageal reflux disease. What does gastro mean? Stomach. Esophageal is your esophagus. So if it's gastro in the stomach, esophageal reflux tells you what it is. It's the acid from the stomach going back up into the esophagus. It's refluxing back in there. It's the backward flow of stomach acid into the esophagus, and it typically has symptoms like burning and pressure behind the sternum. Y'all know what the sternum is? What is it? Breastplate. Alright, so they'll feel like, oh, I've got this bad burning sensation right here in the joint right here. What's everybody's first panic? Heart attack does, and it's not. So they'll feel like it's heartburn. They'll have a dry cough. Why do you think they're having a dry cough? Irritation. And hoarseness. Why do you think they're hoarse? That acid is just eating away at their esophagus, and so they'll have it. If it goes up high enough, it goes, they burp and it comes up and then they swallow it. It's just right back and forth and just makes them real hoarse. And they'll always have a sore throat. Same thing, because it's acid. It's not meant to be up that high, and so they have a lot of irritation there. Okay, H2 receptor. This is what you give them for a med for it. H2 receptor antagonists. What are those? Axid, Zantac, Pepsid, Tagamet. Those are just for your mild GERD. Okay, they start with this. It's just an acid blocking. H2 is that's what these drugs do. They block that acid receptor on the cell, and so it prevents it from or lowers the acid in the stomach. Therefore, if there's less acid in your stomach, there's less reflux, right? All right. And then they can do proton pump inhibitors. These are the PPIs. These are older ones like Prilosec, Acifex, Prevacid. That's a little more severe. The first round doesn't work. And then if it's gotten bad enough, the acid will actually just eat through the lining and causes an ulcer. And so that's when they have anti-ulcer meds, Carafate or Sucrate. Sucralate, have y'all heard that one? It's all like a thick oil almost, and they drink it and it coats. Carafate. Sucralate, that's old. It's been around a long time. So then they give them that to help coat over. So it's just like glazing over a pothole or something in the road. It just coats it so that acid doesn't irritate it.
Is Carafate over the counter?
I don't know if they have it or not. I don't know anymore. Maybe. It's been around forever. And then the last one, like severe enough, they'll give you Reglan, metoclopramide, and you can give Reglan. It just helps promote the peristalsis, and so that empties that stomach acid out quicker. This makes everything start moving. It's an H2 receptor, so they start with it. It's a real basic one. It just helps lower the or blocks the acid. So those are just some of the things they just try to do. That I call it the Meson, but it's Meson fundoplication. That's just a surgery they can do that tightens that sphincter so that acid doesn't reflux as bad. Okay. If GERD is left untreated, a lot of people think, oh, it's not going to kill you. It's not a big deal. So it kind of gets passed off and they just deal with it. But if it's left untreated, it can lead to what's called a Barrett's esophagus, Barrett's. Barrett's esophagus, it's like precancerous changes at the esophageal.
Can you say
Barrett's. It leads to esophageal cancer.
So after you completed Barrett's, is that an indication you will see cancer, or?
Well, the GERD leads to precancerous cells because it's irritated so much that the cells are trying to constantly overgrow, and all cancer is an overgrowth of cells. So when you get Barrett's esophagus, now you're getting a narrowed esophageal pathway, and so that's what's called Barrett's esophagus, and it's just associated with esophageal cancer. So just kind of know, in case you see that term Barrett's esophagus, it's from not taking care of that reflux. That acid has eaten away at the esophagus, and now they're precancerous. Okay, I just they can give them meds, they can do surgery. Of course, we can alter our diet, but who wants to do that? That's not fun. Okay, and then here's your nursing interventions, because you need to know these, and that's how they want to know, not just that you know what something is, they want you to prove to them on the test that you know what to do. So you provide your patient education about diet, meds, stop smoking, because we know that decreases gastric acid. Avoid tight clothing. I mean, how many of y'all have been to the all you can eat buffet and you have to unbutton your pants? Not that I have every weekend, but it does happen because it's tighter, and so you want them to avoid tight clothing because it's supposed to push that, pushes on your belly, which pushes that acid back up. Okay, and then avoid working in the bent over position. I know it's hard for some of y'all on this side around. You can't bend over with acid reflux because then it's going to come out easier. So, and then so it'll make it on the bed. We're just dirty. We need a weekend.
Yeah, we did.
So just like I said, put them in semi-fowlers or high fowlers if they're a patient, because we know we want to use gravity to help us, right? So let that acid go down. Tell me some foods that they should avoid. Look, so this is another thing I like to ask you. What kind of food should you take patient? Spicy foods, for sure. Any kind of acid, like tomato base. I love salsa, but it's full of good acid. Cola, sodas. What else? Beer.
That beer though.
Good stuff. And so, how about should I eat 3 big meals a day? Please, for the love of God, if you have any kind of question about that, always pick 4 to 6 small meals a day. That is going to be the answer because they want us, that's the thing they want everybody to do now, right? Instead of eating 3 big, huge meals that we gorge ourselves, small, frequent meals is a better answer. Heart's coming out.
Bad for the kids.
They say it's terrible for the kids.
Yeah.
I remember that one.
Well, looks like I'm
Yeah.
My daughter had to get a nausea shot because it was in her stomach.
Really?
4 to 6 more days.
It's like pepper, isn't it? Like the ghost pepper?
Well, it's just the dye that's in it. Red dye is pretty much in everything now.
But I mean, like, what do they use to make it?
Away from me.
I don't know, but she can't do anymore.
That hot cross.
Oh, yeah.
So anyway, just know that small, frequent meals. Nothing before bedtime, because what are we doing when we lay down? If we lay down flat and that acid goes right back up, okay? So, low-fat diet, high protein, because the protein helps it digest it. Yeah, it doesn't have as much acid. No alcohol. Eat really slow, chew well. Keep your head bed up. They may have, these are the people that come to eat, blocks on their bed to keep their head bed up. And no chocolate. Chocolate has got acid in it. I hate to hear that. It's one of my friends. And then encourage them to stop smoking, all that other stuff, okay? Alright, here's the thing about carcinoma esophagus. Just know same thing. Alcohol, tobacco use, acid reflux, and obesity. All that leads to reflux, which we already said leads to esophageal cancer. Okay? Kind of same symptoms, difficulty swallowing, because now I'm irritated all the time in my throat. Cough, may have vomiting, and then I have hoarseness, okay? Any kind of cancer treatments, it's going to be radiation, chemo, or surgery. That's for any kind. This is just a term that was on here, just so you can know what it is, in case they throw it out there. Cardiospasm. This is for 20 to 50-year-old male or females can get this, and it's just an inability of that muscle to relax, especially the cardiac sphincter, which is right there at the top of your stomach, and so that will start spasming, and that's why people like them think they're having a heart issue as well. Okay, so just so you know that. They have difficulty swallowing. They jump with the G's. And so,
What medications do they do for that?
give them like anticholinergics if you're having a reaction with choline. So acetylcholine. So calcium channel blockers to reduce pressure. But they definitely dilate it. They go in and dilate it. This is real gross. I found out this last time. If you have this where that sphincter's clamped off, so all the food is blocked between your mouth and your esophagus, right? It's not going into your stomach. Guess how much it can hold in your esophagus? That's a tiny little food tube. It can hold up to 1 liter. That's an IV bag of food. It stretches that much. The big IV bag.
But if it gets up to that high,
So then you start, of course you're going to have trouble swallowing because you can't get it down. It's full. And then you have risk of aspiration and you're going to vomit and all that other stuff. So I just thought that was kind of neat. So there's that. There's that to look forward to in life. Alright. Gastritis, peptic ulcers, and cancer. We're going through these. And I think y'all have a little handout from this, right? Gastritis is just an irritation of the lining of the stomach. All of these GI stuff is pretty much going to have the same kind of symptoms, right? Anything with your GI, with your stomach, you're going to have nausea, vomiting, diarrhea. 3 things everybody hates to have. Fever, headache, loss of appetite. When your stomach is hurting, you're not going to want to eat, so you have that anorexia, that loss of appetite. This is just where the acid has gone through that lining and is just eating it up, and so that's why they're having all these issues. Gastritis. Okay? Just means that their lining in their stomach is irritated. What is this word? Hematoemesis. Yeah. Blood and emesis. Yeah. So, and then what's this one? Black tarry stools. Melina is black. Sticky poo. Sticky, stinky poo. So, why do you think that you're going to have blood in your emesis and your stool? If you have gastritis. Exactly. You have ulcers, stomach ulcers. The lining of your stomach is raw now, and you have that little capillary that just leaks blood all the time. Okay? And y'all have all these on your slides. Medical management for gastritis, of course, we're going to give them some kind of med, like antiemetics, compazine, or phenergan, Tagamet, Zantac, to kind of help get rid of some of that acid and get it going, get it out of the stomach. Maybe if they're bad enough, an NG2, where we have to lavage or wash out their stomach. And then, of course, we're going to try to remove whatever that's irritating them. What is the cause of all this? Strict gyno, we're going to keep them MBO, because if your belly hurts, do I want to put more on you? No. So let that belly cool off, and then they're going to advance as tolerated. So let's say they're really sick, vomiting, they've had, yucky vomit with blood in it. We put the NG tube in it, we washed them out. Okay, it's day 3. They've been NPO the whole time, right? Because if you got an NG tube, you should be NPO. Otherwise, it's going to suck it right back out. So we got them. Now we're going to take the NG tube out. What kind of diet am I going to serve them? First time. Exactly. Start with the simplest. They're going to be hungry, and they're going to want something, and they're going to be mad. But you know what? You start with clear liquids, and you advance as tolerated. So let's say we start with some broth, maybe some juice, apple juice. They tolerated that. Now what can I move them up to the next meal? All liquids. Yeah, puddings, jello. So then it's still liquidy. It's easy for the stomach to digest, but it's got a little substance to it, so they feel like they're eating. If they tolerated that, great. But what if they didn't tolerate it? What do I have to do? Go back to clear liquids. Good. So just remember that as far as diet. That's for anybody. That's doing it. If they ask you a dietary question, if they're throwing up whatever you give them, you go back down the scale. If they're tolerating it, you go back up. I think we have a picture, right? The little guy looks like Al Capone to me. And it kind of has a little bit of all of it. Like it has gastric ulcers, which is what we just talked about. Y'all know what HCl means? That's hydrochloric acid in their stomach. They may have pain with the stomach gastritis half an hour to 1 hour after meals. Why do you think it's so soon after you eat gastritis? Yeah, you just ate and you're putting food on a raw increases the pain because you're raw and irritated, right? And so now, and it just kind of gives you all the different kinds, okay? Duodenal is down lower in the intestine, and these are the stresses, just different factors that cause it. Further down the GI tract, ulcerations in the mucous membrane. Y'all ready? Yes. Ulcerations in the mucous membrane it's further down the GI tract. Okay, it's not just in the stomach now. It's past the stomach into the duodenum. Y'all know what the duodenum is? What part of your body is that in? Right, small intestine. So it's gone down even further. Pain is their main symptom of this. It's a dull, burning, just gnawing pain. Like, they can tolerate this. They're like, every time I eat, it's bad, but I can still eat. They get through it. So it's just in the epigastric region, right around their stomach. This is for the duodenum. Okay. Again, we're going to insert an NG tube to check that gastric contents. We're going to see how much acid they have, what level of that. Of course, we can give antacids. These are like Tums and all that kind of stuff over the counter, right? To neutralize it. Neutralize the acid. These are people, when you put the NG tube down, you might get the coffee ground emesis back. Y'all know what coffee ground emesis is? Blood. Old blood. It looks just like, after you've made a pot of coffee and it's sat there for 3 hours, you take the wet coffee grounds. If you were to dump that, that's exactly what you're sucking back up in the liquid. It's old blood. It's dark, old coffee ground emesis means there's a bleed somewhere down in that low GI. Mid GI. And so they'll have coffee ground emesis. There's on page 1419 and 1420, there's a list of farm meds. If y'all are doing farm flashcards for this one, it's all the stomach meds. Kind of the same thing. If you have H2 receptors, those are blocking the stomach acid. You do not give those within 2 hours of antacids. Why? You can't give an H2 blocker and antacid together. Really, you don't want to give anything with an antacid. Yeah, they're going to fight each other. Okay, so just know that. You don't ever give anything with an antacid. Alright, and there's all that, like I said, it's on page 1419 and 1420. Now, there is a bacteria that can cause stomach ulcers. H. pylori. Has anybody ever had that? And describe how you felt with it. Nauseated.
Everything sits there and it feels like you're in a ball. It feels like you're on fire. And it's stressing.
It is stress-induced. It's a bacteria that normally our body can fight off, but when we're stressed, our immune system's low, it attacks us. And it attacks hard. So they have to give them a prep pack or a medication, antibiotics to kill it. Okay? Nursing interventions for Peptic-ulcer disease, same thing. Intermittent suction, because do I want to just keep suction on full time? Why? What's the risk of having full time suction on? What's it do? Well, you're going to get rid of everything. Yep, all of your lymph nodes come out. But what rate goes up and blood pressure goes down, you are in trouble. Or bleeding somewhere really bad. Okay. Cancer of the stomach. You've got this slide, so we kind of just skip over it a little bit. But just know it's more common in men. And look, it's more in the. That's kind of interesting to me. Wonder why they have it more often than we do. You think they're higher stress than us? Yeah, we're a little bit laid back, aren't we? So, the Japanese, like, they never take days off. They don't ever do anything. They're always working.
They're so productive.
All right, so just know that one, you know, in case you see it, it's very similar symptoms. They're going to have no symptoms at first in the early stages, but as it advances, they're going to be pale and lethargic because they're anemic. Why are they anemic with stomach cancer? What's in our stomach that we need? Think back to your intrinsic factor. Yep, intrinsic factor is produced in the stomach, and what does the intrinsic factor help us do? B12, and what is blood made out of? B12. So if I have stomach cancer, my stomach's not working, I'm not producing intrinsic factor. Therefore, I can't make blood or absorb anything. B12, good to make. So see how that all, it's a circle of life. And then they become anemic. Okay, there's their symptoms. Y'all have all these on your slides, so I'm not going to go over them with you. You can read them over when you get home. If you're, you know, it's interesting.
You said we have a test when we come back, right?
Let's see what's on our new syllabus. I think that's just a reading quiz, right?
Yeah.
Yes, you have you have a med calculation test number 2 when we come back the next Thursday, not next week. And then a reading quiz on Thursday and a reading quiz on Friday. But remember, the reading quizzes are going to be after our lecture.
But the exam is not till week 9.
Yeah.
Do you have
You'll
any
give us
extra
a
math?
review week day.
Do you have any extra math practice papers?
I do. Somewhere. How about them? All right, so let's get to this real quick so it'll be good and y'all can all listen to it Friday. Inflammatory bowel disease. I think this is on your handout too. Did I give you one for inflammatory bowel or Crohn's? Yes. This is our last thing that we're going to go over for today. Yeah. Okay. Now, we're in the bowel now. We're not in the belly. We're not in the stomach anymore. We're going to move down the GI tract to the bowel. Ulcerative colitis. What does colitis mean? What would you just guess that? There you go. And maybe it's ulcerated, right? It's ulcerative ulcer. Alright, these signs and symptoms, they have diarrhea that may contain blood, mucus, or pus. Not a good day. And so they'll have abdominal cramps because they're having diarrhea. Usually if you're having diarrhea, you're having abdominal cramps with it. They go hand in hand. Moderate up to 5 stools per day with this. Can you imagine? And then severe, they have 15 to 20 per day. Like, how do you function in life? You know, how do you love your job and just getting back and forth to the bathroom? So they'll do a barium enema to help diagnose them, but it's really painful for these folks. Okay. They'll have rectal bleeding and abdominal cramps. Obviously, they're really irritated. They're going to be lethargic. Why do you think they're lethargic? They're emptied out. And then plus, when when you're going through that phase, you're not absorbing, so you're not getting any nutrients. And then what little bit you had, you excreted it, so all of your electrolytes are gone. Frustration. Can you even imagine? And Lord help the person that has to come in behind you. You know, how awful and embarrassing and frustrating for the patient. You know, and then weight loss. Because again, it's shooting right through them, so they're not absorbing any nutrition. And then fever and tachycardia. Okay, fever just because they're in a state of irritation, and the body is trying to have an inflammatory process that speeds up the metabolism, so you have a little bit elevated temp. Tachycardia, the same reason. So here's your medical management. Here's the team is going to do, not just the nurse. We're going to give them some kind of inflammatory response modifiers. What do you think that is? Steroids, corticosteroids. Anything with itis, I-T-I-S, if it's inflammatory, you can give them anti-inflammatories like ibuprofen or relief, but you can also try steroids. Okay? infection if it's bad enough. Alright, so here's what the nurses gotta do. You gotta do all this. Assess, right? You gotta look at the bowel patterns. How many, you gotta keep up, how many times a day did they go? Right? And if you're not gonna have to be measuring this in cc's and milliliters. It's times 1, times 2, times 20. Okay? Treat and assess their pain, or how bad are they? Do they need something right now? Is it just diarrhea? Can I give them some Imodium AD to slow them down? Or do they need something strong? Because what do pain meds do to our colon? Slow it down, right? Nutritional status, I'm going to be watching to make sure that they're eating what's on their tray, and if not, working with them, trying to figure out the dietary, figure out what they need, and then maybe doing lab work to make sure that they're not dropping too much and getting anemic if this is a chronic, ongoing patient that you take care of for a long time. Coping abilities, you got to do a lot of mental health nursing with these type folks. They're depressed, and they're frustrated. Patient education, talking about what they can and can't eat and things they need to do. And certainly if you're going to have surgery, you're going to do the pre and post-op care. Nursing is a lot of education. You have to do a lot of teaching for these as a nurse. Doesn't mean ulcerative colitis and it's to avoid stress. When you figure out how to do that, please let me know. Please let me know. But you try to teach your patient that. Those kind of patients are definitely high risk for right? So Crohn's disease, this is the one I gave the picture on. The little lady sitting on the commode, bless her heart. This is in the GI, anywhere really in the GI tract. Ileum or colon, the other one's just in the, okay. Characterized by inflammation of segments of the GI tract. Cause really is not known. They think maybe it's linked with genetics, environmental factors. Are you around somebody that's stressing you out? Your family life stressing you out? Is it something in the water where you live that you're drinking, or is it your dietary, whatever it is. So that's environmental factors. Maybe an immune link. They always go to that if you autoimmune. This is the difference of this one, okay, from ulcerative colitis. That's usually, any age, but it's usually older. But with Crohn's disease, it occurs during adolescence and early adulthood. So you kind of need to know that. That's something important, because what they'll tell you is all the symptoms that this 14-year-old girl is having. Is it ulcerative colitis, Crohn's disease, gastritis, or diarrhea? So when you see them specify an age or ethnicity, that is a clue. They're trying to tell you, because that's what you have to determine by. So Crohn's disease is in younger people, okay? And it has the cobblestone appearance. It almost looks like scales, because what's happening that the body is trying to heal itself over and over and over again, and so it'll just scab over almost. So let's say this is the colon, and it has a cobblestone appearance when they do a scope on them. Like that's the lining. Looks like that, where it's just where the ulcer was, and it tried to heal itself over. So the whole area will look like that, like cobblestone appearance. That's what it means. Now, that's just like scarring. So if our intestines are where we're absorbing stuff and they're all scarred over, how much are we going to be able to really absorb? Very little. So these patients are very, usually anemic, malnourished, very skinny, very, emaciated looking, because they're eating, but nothing's being absorbed. So it's a real big issue for them. Just remember, this one is, like I said, with younger people. Diarrhea, fatigue, abdominal pain, same reasons. We're having diarrhea, we're exhausted, we're having abdominal pain from the diarrhea, or weight loss and fatigue because we're not absorbing anything. They'll have right lower quadrant pain. That's a classic sign with Crohn's disease. Weakness also, that's how abdominal cramps. Right lower quadrant pain, because that's where the colon is starting to descend. Frequent bowel movements, fistulas. Do y'all know what a fistula is? Yeah, it's a hole that forms between two organs or an organ wall out into a cavity. So it can irritate so much, and then if it doesn't scale over or cobblestone over, it makes a hole. And And then now all that raw sewage is going out into your peritoneal cavity. They also have what's called steatorrhea. Y'all remember that term? It's not on here. It was in your book. This is how it's spelled. This is steatorrhea. It's fatty stools. Why do they have steatorrhea? Fatty stools. Yeah, exactly. They're not absorbing anything, so it's shooting right through them. So then it comes out that real fatty, oily, puffy-looking stool. So steatorrhea is a fatty stool or feces. Okay. 2 more slides, y'all. Here's your medical management. Again, any kind of anti-inflammatory meds we can give them, like NSAIDs, steroids, because we want to cool that colon off and decrease that swelling. Multivitamins. They're probably not going to absorb it, so a lot of times they'll give them shots, injections for that, or give it IV. I can give them a little IV drip with high-powered vitamins in it, and they just give it to them like over 30 minutes to an hour, once a week, to kind of boost with that. Immunosuppressive therapy, they can try those because that helps. Hopefully, that they think that might help the body not continue to fight itself, and they can heal. Stop that inflammatory process. And you're going to give them dietary modifications. They need a high protein, high fluids, and water. Would you want to give them a lot of fiber? No, because they're already having trouble. No lactose, no roughage, because that just makes more gas and more pain. And they can have no sugarless gum or mints. Like sorbitol that's in all that sugarless gum and stuff is bad for them. No caffeine and beer. And then, of course, they can have no beer. And they can do surgery where they try to resection that part out, but it literally spreads through their whole colon, so they usually don't do well with that. B12 injections, like we said, for absorption. And they need iron injections. Remember how to give iron? If you're giving iron, IM? D-track. And if they're drinking it, with a straw because it stings their teeth. Very good. This is the last one for today. I know y'all are sad. Nursing interventions provide nutritional education because you're going to have to teach people how to do all this. Monitor their INO closely, and then assess and treat their pain, because that's really all we can do is just kind of help them, control their pain levels, using comfort measures. Bedside commode, because they're going to be going so frequently, and providing emotional support, okay? Any questions on that? It's pretty much the same thing over and over with the colon, because it's one-way track, y'all.